Hello and welcome to episode 20 of the Auditing Antics podcast. So today we're going to be diving into what is really going on in the world of HCCs. We have the announcement from CMS that they're going to be increasing their funds, their focus on RADV audits. So I have a special guest, Dr. Khush Singh, here with me today. And he is a strong player in this part of the industry. He himself is a trained clinician, but he does also have a lot of experience in the coding and auditing side, and that focus that we have in the health information side of the industry. So I always get a lot out of the discussions that we have, Khush, and it's really good to have you here with us today.
Thank you, Stephanie. It's a pleasure to be here
Yes.
and share our mutual experiences in this industry. So thank you for inviting me.
Yes, definitely. All right, so to get started, I wanted to talk some about the current environment, but also, what it is that led us to this point with CMS increasing their focus, increasing, the power behind bringing auditors in and really taking a look at HCCs, where this money's going. I know for me, I've always known there's a large dollar amount tied to this, but there's a lot of things that happen in the background as well that play into all of this and really play into non-compliance. So if you could just give some initial thoughts on that history part of it and really what's led to this current time.
Yeah, and I think you're bringing up a fusion of a lot of questions, like why did we land up at this place? Like there has been numerous articles, news reports in major publications to the point that this has been talked about in various circles, especially clinicians who are participating on the health system level, who are not a part of the Medicare Advantage plan, but still a part of the healthcare workforce. And a lot of fellow physicians and clinicians have asked me the question, like, what exactly is this problem? Even my dad was asking the other day, what exactly is this problem? I said, well, let me explain you. If I put out an incentive to say, go get me as many as pennies that were minted in year 2000, and there is, for every penny you're gonna get $1 back. What do you think the whole town will do?
Yeah.
They rush to the
A
bank.
hundred.
They rush to the bank and say, go to every bank, get every penny stack, and find the penny which is stamped as year 2000, right?
Yeah.
So because immediately you're gonna get $1 for it. So the whole country will rush if there was such an announcement.
Hmm.
So historically, what happened is Medicare Part C was created in order to control the overspending in Medicare. And this was a public-private partnership. Long story cut short, CMS announced a model saying, we want to give out contracts. You take care of these patients. Every claim is to be paid by the MA plan, Medicare Advantage plan. Let's put out a structure. Let's put out a Medicare trust fund allocated for this kind of partnership and a contract, which is called health plan contract, and with the CMS. So there are guidelines. You take care of the patients, take care of their health, make sure they are seen at the right time by specialists and doctors. These are your responsibilities. These are the quality measures. And the program kept on evolving. But underlying how it was funded and still being funded is based on the risk adjustment scores. And statisticians laid out a program listing out the codes that would increase the risk score value of individual beneficiary. So Medicare beneficiary 65 and above would be seen by a provider, and if the patients are reported to have these conditions, which are called HCC, higher care condition categories, and the diagnosis and the diagnosis code gets to that category, if it is mapped according to that file, the RAF score will bump up, and that RAF score bump up for that population would increase the funding for the plan. And that drove the decision that why this reporting of diagnosis becomes very important. Now, there are guidelines out there which also put the compliance guide rails that, hey, make sure you're reporting according to these ICD-10 guidelines, you follow the procedures, these conditions should be evaluated, monitored, treated through the year, patient must have these conditions. And that's where the whole program starts to gain traction. And as you know, there is kind of a gold rush there. And
Mhm.
you want to make sure the documentation is complete. CMS also laid out a plan that they would be auditing. For a number of years, the auditing did not happen. And even previous auditing that happened in the time frame of, I believe, 2012 through 2015, not a whole lot of audits happened. And even before that, I think the program had initial studies and validation audits, which were going back to 2009, 2011, 12 timeframe. And I have to go check those date timelines to be very precise. So not a whole lot of audits happened. And if the audits happened, they did not collect the difference if the audit failed to show. So this was kind of an evolution where CMS and the audit program could not be enforced at that time. And meanwhile, as the program evolved, more beneficiaries were signing up, health plans are expanding their footprint, and we know all major health plans expanded a lot. And this took a membership level from mere 10% to 51 some percent at the end of 2023-24 timeline. I mean, there was a massive increase in Medicare Advantage. The main emphasis was the business model, that how to increase the funds, how to increase the RAF score, how to make sure the members are given the benefit and give them extra benefits of gym membership and other areas where they could get supplemental benefits for healthy lifestyle, which is all good. It's all good if this program can run effectively, compliantly, and audits are good, and program audits are for member appeals and grievances are taken care of. Those pharmacy benefits should take it. This is a beautiful program. It should be run in a good way. Now, what has happened is that we saw an incremental collection and reporting of certain diagnosis codes that skewed the data. And we have some initial data that shows the prevalence. Like one is that this program is about 66 million members right now. And Medicare fee-for-service data shows a certain prevalence against, different categories of diseases these patients have, which is a classical study. And if you read through this data set between 2018 through 2023, those 5-6 years of data, you will see the prevalence of certain conditions such as obesity, morbid obesity, depression, myocardial infarction, stroke prevalence. This is at a certain level, like it's a single digit level. But when you compare it against the Medicare Advantage reported data, it multiplies just because over-reporting happened. Now, statisticians have given the argument like, oh, underreported happened in fee-for-service. Well, underreporting is very, is subjective to some of these extreme conditions are seen in a hospital, and hospital does report those conditions when they are actually treating through the hospitalization. Acute stroke will be hospitalized, and some of the other acute conditions will be. But when we see this data coming as from provider offices, some are not valid at the current time because patient was hospitalized 2 years ago, had that acute condition as a history of. So you're looking at a big variance in how Medicare Advantage data was reported. And that took the attention of the government. That took the attention of OIG, Government Accountability Office, MedPAC. And over the years, as I've been following this from 2018 19 timeline, just before COVID, OIG had reported out that they're looking at the chart reviews being as a single source of HCCs that are being reported by the MA plans. And billions of them, they at that time in the study, are reported to be paid to the MA plans based on chart reviews. And this
Mhm.
was quite an astonishing study when I came across it. And that just gave us an idea that why this is going to become a very big problem and how the government is going to take an action on it. It just took them 5 years to take a final action on what we see this year, and as the new government came in. And I actually support and welcome this decision because it's all in public interest.
Mhm.
Because certainly there are a lot of fraud-based abuse cases, and this is where we are at in 7 years. It took us maybe the OIG may have a very strong and bold numbers, but I think they are evaluating it across close to 60, 70 billion plus in overreported diagnosis alone, which don't substantiate. I mean,
Mhm.
it's a very, very big number to deal with, to think about it.
Well, and up to this point too, I know a lot of the cases that I have seen where they're going after some of the larger payers have really been based on whistleblower cases, largely in that arena, not necessarily these increased audit divisions within the government going out and, like you said, these chart reviews, them looking at everything individually. There's a lot that happens due to people who are experiencing it internally, seeing, people continuing to not listen to them, to push forward, push against the line that is, questionable from a compliance perspective. And, that definitely is going to be changing with this um, new forefront that we have coming with auditors ramping up. I know I've seen companies that are hiring on a very high level that to me appear to be hiring people getting ready for these government contracts to come in and do these chart reviews. But I think it's going to be pretty eye opening just based on, the behavior that we've seen from payers in the past that do skirt the line or do everything possible that they can to report these conditions to raise those risk scores and, obtain that money.
Yeah, very rightfully well pointed out. This is where I think, to put an example, that if someone has a flat tire while driving, they don't go to a dentist,
Mhm.
right? Dentist not going to fix a flat tire.
Right, right.
So hiring someone at the top level of risk adjustment value chain who doesn't know anything about ICD-10 coding compliance. I mean, respect to everyone who are my fellow colleagues here, but those are the ones who have to hire the right people, saying,
Mhm.
okay, I'm at the top of the leadership. I need the strongest person with the strongest knowledge base or a team of experts that can build the program right.
Yeah,
Because
yeah.
we cannot allow, as a if I was to speak for a large organization, let's say I'm at the top of a MA plan, my first priority should be, are we collecting the right data, and is it valid? Does it pass an audit? Because end of the day, MA plan is going to sign a release certifying that the best of the knowledge, certified under penalty of perjury, is this is all correct data, and you should transfer over these, hundreds, thousands, or millions of dollars, whatever the amount is,
Mhm.
as a reconciliation. And this is where everybody relies on other experts' opinion.
Yeah.
They have a team of analysts, team of other subject matter experts who validated the data, or they were relying on their vendors, or they saw that the vendor actually brought in great benefit in tune of millions of dollars, and they could not resist it.
Yes.
Right?
Yeah.
I've been a part of those conversations many times, that I had to actually simply keep quiet and say, okay, I don't know what's happening, I'm not going to stay here. Right? Those conversations are pretty much like, hey, just bring in 30,000 charts. We will, run through this and code it and get you ROI would be 20x. I mean, it's difficult to resist if you think from the business point of view. If you're running a business and say, I'm going to give you bananas and each banana is 1 cent and you can send for $1, you will have a house full.
Mhm.
It's a good, but that is not what is risk adjustment. That is not healthcare, right?
Well, and that's one thing that I have a large concern related to, because for me personally, a lot of my experience in the risk adjustment side is working one-on-one with providers and organizations to make sure that at a base level, the documentation is there from the face-to-face visits to support hopefully more specificity. But one of the things I keep hearing more and more, and now it's increasing, is all of the incentives that the payers are putting out there. And I actually have talked to our mutual friend Ed Baker about this. He's an attorney that actually does represent whistleblowers, and my concern there is that they're pushing them to a point, and then that provider, if they choose to take that bait and they're still doing it incorrectly, they're also taking on a lot of risk. And when we have payers that are saying, oh, we want you to add, I think the one CPT code that I heard was 96160 to every claim, and then we will pay you, I'm just going to throw this out there, $100 every time you put that code on the claim for obtaining the risk adjusted codes as specific as possible. They're just baiting them over. And on the pro fee side with the providers, we also have issues related to the different EMR systems. We have Epic, NextGen, eClinical Works, all of these large organizations that are allowing functions where a provider can push a button and then all of these active problems are being blown into their assessment and plan. They think they're doing a good job. They think they're capturing what we want. But ultimately, if we go back to that base level documentation, it's not supported. And I have a lot of concerns because I think what we're seeing now, this pressure from the government to the payers, is going to trickle down more than it already has to the practitioner level. And we're going to see a lot of things, coming out of this, whether it's related to, performance scores or things with contracting with providers, or even paying out the claims. I've actually seen a lot of claims that will kick out and deny because the combination of diagnoses aren't accurate based on an ICD-10,
Mhm.
guideline.
Mhm.
Something that we know that exists in a book, but there's no way
Mhm.
every physician and provider are going to know that. So I have a lot of concerns with the accuracy of information, not just from the payer's behavior in skirting the line, but what they're tempting and baiting our providers to do.
It is very tempting. I have spoken to several physicians in my closest circle, which are part of um, this value-based care arrangement, that they have actually spoken in confidence to me, saying their salary and bonuses are tied to these things,
Hmm.
right? And this is where it has gone, I think, too far extreme.
Yeah, yeah.
Medicine is a very noble profession. Providers should not be, put in a bait switch kind of a situation and tie these incentives in the way some contracts have signed up. I've seen some of those where it is going to be very important is for the providers themselves to realize what are they doing. And there are a lot many, I would say 90% of the providers are truly innocent on this area, which they think they followed a particular person, they believed in the guidance, and it's a basic human nature. If I have a very nice looking document and have a very good stamp on top of it, like a big brand name thing, and it is created for the purpose of upcoding,
Hmm.
the doctor or the whole staff is going to believe it. Oh, it's a printed document, look at this, right?
Yeah.
But you look from the compliance angle, you're like, wait a minute, what are you saying? Are you saying every person in this world who has 2 points of risk factor is equal to secondary hypercoagulable state, really. It means everybody who is above the age of 75 who is a little bit weak, fragile, has malnutrition, or had a CAD, coronary artery disease, in the past, is meeting like 4 points and should be listed as secondary hypercoagulable state, and that leads to a risk score amounting to $2,500 a year. I mean, seriously, this means that it's a crazy document to be educating the providers with. That every single episode of worriness, anxiety is equal to major depression. I mean, someone's dog passed away, the person does not go into a major depression until otherwise. Major depression is a very, very big clinical, criterias are, if you look at the DSM-5 criteria, it shows criterias that has a clear picture of how a provider should assess based on organic nature of the disease. It should not be attributed to any medicine. It should not be attributed to any other comorbidity. This is all, in a certain way, a diagnosis of exclusion. But just one episode of anxiety or depressive phase, like somebody's over worrying and little upset of some, family circumstances or anything, that is equated to major depression. That's wrong to call it major depression. Just because someone was smart enough to bring up and saying, "Oh, please write the severity; it's moderate," and then don't put depression, put major depression. And people turned around and twisted their EMR code selection drop downs because of that. I mean,
Yes.
I don't know
Yeah.
what to call it. Stephanie, what do you think it should be called as?
Well, I've seen that where the different pick lists and things like that are sorted in a way where it's going to show them certain conditions over another. And, I've actually had discussions with my physicians and practitioners about this because when we talk about risk adjustment, I have to say multiple times just so that I know that I've made it clear and I'm comfortable with my message that first comes their clinical decision making. But to your point, what's becoming very difficult is that they don't understand necessarily what all of the different code sets are. Or, when we talk about diabetes and the diabetic complications, they don't know what all of those codes are. So it can come down to things, to your point, with that pick list and what's dropping down for them to look at, maybe as a favorite. But the other thing I find is that sometimes looking through the system, it's hard to find more specific conditions, so they'll pick what is there, what comes up easier. Or, they'll pick the unspecified because they feel like that's, just easier, it's top right in front of them. But, all of these different things are still leading into these issues of the wrong diagnoses being selected. And, when we think about the fact that that's going out on the claim, what are your thoughts around the false claims and what this could potentially be creating? Because a lot of times we think about that from just the CPT perspective. But I really wonder now, number one, what the government's insight is going to be when they get eyes on documents and see that we have, you know, 15 diagnoses listed, but it just says they were there for their annual wellness with no other data to be found. What are your thoughts on those potential implications for the provider's part in this as well?
I think you're opening up a very, very big can of worms.
Yeah.
you know,
And it's there, it's below the surface, right?
it's below its surface, and it's actually right in front of it. And to our audience, I mean, if you haven't stepped into a medical practice and seen the operations and yet claim to be doing risk adjustment and be on top of your license, I mean, rethink twice, because that what you anyone in this area should be knowing about. Risk adjustment coders, auditors are very well versed with documentation reviews, but one has to really see what happens in an encounter. I can share my personal experience. I have seen providers at a medical practice listing out 15 diagnoses or even 10 diagnoses in 5 minutes. The patient is in and out And what I've seen, I could not believe, like, somebody's actually signing away their license to practice doing that.
Hmm.
In 20 minutes, that practitioner just saw 5 patients very quickly. And in our audit review, we found that this was like copy paste clone from the previous
Yeah.
document.
Yep.
And each one of them had an average of 10 plus diagnosis.
Hmm.
And I just could not digest that. It's simple as that. How
Yeah.
can someone
Yeah.
see, like, as a physician, how can someone really see a patient and assess 10 diagnoses and do that? Because the EMRs are built for volume.
Hmm.
The basic reason why this all started and it's still multiplying is it goes back to another fact which is unrelated otherwise, but I find this connection very intriguing. Is EMRs were created to get rid of the administrative burden, which is billing and coding. Everything was paper chart, and government wanted efficiency and the whole meaningful thing. But the templates and every feature was created like, please send the bill out quickly. I cannot afford a coder and a biller in my office. Right? That,
Yes.
that was the approach. So
Yeah.
now it went too far, and we still have billers and coders, and very well they are needed,
Hmm.
right? To be as much as AI can come in now, we have to very very carefully select what are we doing with that workflow. But if you go back and see, any EMR created was complete a chart note, these diagnosis, this is provider's decision, pick the CPT, pick the diagnosis, and bill should be out of the door quickly.
Hmm.
Why everybody is looking at the volume based care,
Yeah.
VBC not as value based care, VBC as volume based care.
Yeah.
So we are moving so quickly that copy paste function is made it easy. Selection of diagnosis of the choice, and the RAF score is calculated from only the HCCs. In several many reviews, every documentation is about an HCC,
Yeah.
90% of the times. And that is a very big red flag. Like, why just HCCs? Why the patient doesn't have anything else going on? There is
Yeah.
nothing else is reportable.
Yeah.
And
Well, and thinking about the clinical workflow as well. So, a lot of times they're told that more from the administrative side. So they're just focusing on that. They're not understanding that clinical workflow, what that needs to look like. I actually had a physician stop me in the middle of an education session related to risk adjustment and ask me in front of the room of practitioners why I was talking to them about this, because the notes I was referencing, which were annual wellness visit notes, were documented by a nurse, an RN, and they were just signing off on them. And of course, on the surface level, I don't know that. It looks like the physician did everything. So it's really scary the extent that that's going to, where, to your point again, they don't understand the risk that they're taking on by doing that. Now, I just put a comment up here. This person, they came across a provider who was listing diagnoses under the assessment. There was no documentation that the condition was assessed or affected by patient care on that date. And then we have another person saying that then, and I've heard this too, you're told that they're assessing it because it's stated in the assessment. So internal policy is to code it. CMS needs to get very clear and leave no room for things like this. And these are the types of things that I think are definitely going to be a problem, because even to that point, a lot of the times when I'm teaching this, I talk about the fact that an assessment never had the intention of just being a list of diagnoses. If we look into what an assessment is, it's the thought process of the practitioner related to the treatment of that patient. So what is their thought about severity, stability, all of those things? It's not just a list of diagnoses. That's what the EMR systems have turned it into. And that's a large part of the problem. Now, when we think about that as well, what are your thoughts on everything surrounding, again, the way that these tools are used? So when we think about the integrity of information and the use of not only the EMR system as we have it now, but as new technology is being added in, What's your thoughts surrounding all of that?
Well, I think the new technology is going to play a very big role in audits, and that's why what what the CMS press release has said very clearly that they have hired 2,000 coders. They're gonna start work September 1st, and they're using technology. And I have some information which makes me think that this technology is smart what they have acquired, and is going to be much more smarter to find out where there is fraud happening. And it doesn't take a whole lot to understand this process. Going back to those comments, I mean, there is some room around making some kind of a subjective assessment like what CMS wants to do. But if you look at the RADV guide, risk adjustment data validation guide to be prepped for audit, it clearly says many things out that should not be done or should not be considered in validating a diagnosis. And to the point, ICD-10 guidelines also keep on referring, and there are various guidelines which say that if they are not a part of treatment assessment at that day and during that encounter, should not be reported.
Hmm.
Now that's where it goes back to the previous question on annual wellness visit. Does annual wellness visit include all the 15 diagnoses? Yes, it should if the patient has it, and if the treatment plan was there. Countless times their argument has been, because I've heard many educators who are non-clinicians and risk adjustment experts, so to say, list out annual wellness visit as a very good opportunity to document. I said, yep, absolutely. If there is evidence for it that you manage that condition, treat it, and the patient has that condition on that day.
Hmm.
If someone as a nurse practitioner is going to, for example, write prostate cancer stable, right? What does that tell me as CMS? What does that tell me? Stable what? Stable active as a prostate cancer, or it's totally done? And further, we went to that track to find out that the patient had a prostatectomy 2 years ago. So every
Yes.
year it
Yeah.
was being carried over as a real condition. Every year
Yeah.
being carried over as coronary artery disease, peripheral artery disease. There is no evidence of DVT, deep vein thrombosis, but the practitioner is rolling it over because that is their policy, that is their administrative burden,
Yeah.
and this is where it's going to go really bad.
Well, and it's concerning, and I've worked different projects from different viewpoints, including, facilities, hospital facilities that have part ownership and an insurance plan, those types of things, which also brings a whole other level of concern. It's very concerning, especially what they were trying to push us to do with risk adjustment, which ultimately I said, no, I'm not doing that. But one of the things that I find interesting that you just pointed out is where they want to be able to go in and just say stable, stable, stable and get credit for that. And, I always look beyond that. It's not just about, okay, yes, the patient has the condition. If they're stable, how is this practitioner monitoring this? How are they managing it? What is their actual involvement? And I've had a lot of back and forth discussions, and some people get upset because they just want to be able to mention it once throughout the year and move on. But how are you really going to back that up? And how do it's the same thing too. If they say, oh, this is stable, refer to cardiologist. Okay, again, what are you doing to address that? How is it a part of your thought process, your care? And, I've seen some issues, and I can't remember the payer, but one of the payers that had to pay back, it might have been United Healthcare. They had the practitioners going into patients' homes, or maybe even just nurses, and the government called them out and said, look, you're mentioning a condition one time in this year period, and one time mention isn't necessarily going to be enough. So, that's going to be an issue as well if we have that type of behavior from our providers in the practice.
Yes, and yeah, I think you have opened up another kind of worms, which is in-home assessments. And
Yeah.
there is OIG report on that one-time reported diagnoses that were nowhere to be found in encounter data before, and
Hmm.
furthermore, no follow-up. That became a big business.
Yeah.
All of a sudden, companies exploded with a lot of, and I think it took away a lot of clinicians to just go and do this risk assessments like air, nurse practitioners, PAs, MDs, and others. I I'm not so much in that favor, except for the patients which do need homebound care or where patients have very least access. A still proponent of this should be brought to primary care. You know,
Yeah.
plan who really wants to care about patients' well-being and wants an assessment plan nurse, or set up a program to bring the patients to the physician and assess them. If they're healthy, this good, and if they are on a stable course of their chronic illness and are on maintenance at doses, good. The whole idea is to keep them healthy, away from admissions, readmissions, help them out, get them what they need, serve the senior population. That's what the program is meant for. It's not meant for collecting diagnoses that don't exist
Hmm.
and then getting the money on. I have an interesting story on this. Is
Oh, yeah.
I I came across a few data points that made me explore more, like what actually has happened with this particular beneficiary. So the story is like 2015, the beneficiary becomes a Medicare Advantage, Medicare eligible, and 2017 was enrolled in a MA plan, and 2018 met a primary care, quick assessments, 15 minutes, nothing happened. 2018-19, primary care just saw the patient and reported like, okay, the patient might have hypertension and all. But patient's own reported version shows that patient had exertion on during walking, dyspnea, which is difficulty breathing, and kind of weakness when climbing stairs and all that, right? So the patient, through the group of family and friends, was advised to see a cardiologist. Cardiologist wanted to see again insurance thing, not in the panel, going and circumventing through the insurance, like, oh, this is not included in this, you should go here or there. Finally, cardiologist made it happen, went for angiography and found uh, areas of where they had to actually proceed with angioplasty, which is stenting of the vessels. So they found four major areas of blockage. So four stents were placed. I mean, it was eye opening. And then COVID hit, post COVID, follow up with the primary care 2021 timeframe. The patient relocated to another state, followed up with a new PCP, nothing major reported, and again had issues, reported wanting to see a cardiologist, cannot find the cardiologist, but eventually found one in 2022 and reported those conditions. And the cardiologist said, let's take you to another scan. We'll schedule you in 6 months, right? In between, the patient collapses at work, rush to a hospital, and finds out there is another blockage in a different artery in the heart, and a procedure happens, like narrowly escaping the full, coronary bypass graft, which is a major procedure, surgical procedure, opening up the chest and doing a bypass, triple or four vessel bypass. Now, following up after that event, PCP follow up missing, cardiology follow up not finding it, and postponing 6 months. The patient develops breathlessness, rushes to the hospital again in 2024, and finds out the heart is failing because some medications were omitted during the course. And during that discovery process in 24, like why the patient had a heart failing despite all this care around him and being enrolled in a very reputed Medicare Advantage plan network,
Hmm.
so as to value-based care network. So three major procedures, two hospitalizations, and total 5 years, 6 years of value-based care arrangement. If you just count the medical bills alone, it's about close to $600,000 in this all.
Hmm.
Could be less, could be 550. Now, who is here responsible for value-based care around this patient as a Medicare Advantage? It's the primary care specialist, the network, the plan, the nurse, the in-home assessments. Could they stop it? They could have. They could have found a way to do it right. And this is interesting because you would want to know who this patient is, right? That patient is my father.
Mm.
We had to circumvent through specialists and trying to get appointments and made sure that he was seen. And the fourth time that relocation happened in New Jersey, went to another network, saw the primary care and then to a different cardiologist, had to find a better cardiologist to see it. And then he prompted, okay, let's do an angiography. But the PCP, the reconciliation of medications, skipped the Eliquis part, skipped another medication part, and no follow ups were there. No close contact, nothing. In home assessments kept happening 3 times. So eventually, when my dad was at school, he nearly collapsed and was rushed. And some things I was away. Uh, I was in India at that time when I got the phone call. I was like, okay, let's get to this part where what happened. Oh, we missed out on prescribing this, and follow up appointments were not set, and this all. I was like, really? That's why the heart is failing, and now he's in better control,
Mhm.
but had to do another procedure. Cardiac defibrillator had to be placed, another expensive procedure. But where was value based care,
Yeah, and that's supposed to be the point of it,
right?
is closing the gaps and having other even other types of staff involved. It makes me think
Totally.
as well of the ACO organization and that setup, and making sure that there's continuity of care and all of
Yes,
those things.
exactly.
Yeah.
Exactly. And there was nothing. And this hit us so hard because we're looking through the data and there is numerous such examples. But where
Mhm.
is value-based care here? Where is the responsibility of the plan and the provider and the specialist when a family had to circumvent and go around and try to get those things done?
Mhm.
And that's
Yeah.
why, we are on a track to actually bring this to census, bring this to through analytics and smart procedures and workflows, that such things don't happen to all beneficiaries who deserve the care at the forefront. Identify and risk stratify those, but
Mhm.
look at the cost that happened
Yeah.
when the plan would have reported all these 5 years of score. They probably could not collect more than 20,000 a year or 30,000 a year. But if you collect a little report, it's five x the amount, 4 to 5x the amount that is spent already.
Mhm.
So it didn't work, right? That's
Yeah.
what is going to drive the medical loss ratio. Plus, this non-compliance within this area is going to raise big questions whether this program is even the participants of the program really realize what are they into. Are they just reporting the RAS score, or are really going to help the patients and helping the patients reduce the admissions and readmissions and do things the right way?
Mhm. Yeah. Well, and that's one thing I'm hoping, with this particular podcast, we do talk a lot of the specifics of the industry, but I'm also hoping as these episodes start to get out there that people can learn more about what this industry is. Because, the patients may be thinking, like you said, oh, I get a gym membership. My aunt had multiple people coming into her home trying to get her signed up for different advantage plans, and they would say, well, we're going to give you this voucher for food for the month, and then you get the gym plan, you get all these other perks, but they don't really understand what else is supposed to be coming along with that actually impacts their stability, their overall health, those things like that can have some external involvement apart from them maintaining their own health, which sometimes just isn't going to happen as well. Now, really quick, so I want to talk about two more things quick, but I saw this comment here, and I think this is a good point when it comes to the standards and what it is that the coding staff should be doing. And, this is something that as I work through projects, it's really important for me to have conversations with staff if I see that they're doing something incorrectly, because a lot of times they're given that direction and they think that they have to do it as a part of their job. But this is something where we need to be mitigating our own risk. And we need to be looking at, okay, is this okay what I'm being asked to do? If I'm being pushed into an area, to add these additional codes or be more specific, or, I've worked with groups where they're designated as coders, but they're really going in and making clinical decisions. And I would see that more from maybe the standpoint of an RN with CDI, but definitely not from someone similar to myself with zero clinical training. So, what are your thoughts there? From my perspective, I always just think get out of there. Don't stay there if you are being forced into these types of things, because your name can be attached to it.
Absolutely. I always advise on err to the side of caution is anybody getting involved in this kind of schematics would be eventually named as. And there has been an example where a risk adjustment director of a health plan
Hmm.
was indicted, and jury actually found not guilty because the person did not gain personally anything, but what the work was being done was wrong. The health plan reported it in self-disclosure, paid millions of dollars back, and blamed everything on that executive. And there are other cases in everything is blamed on the coder, auditor, office manager. Right? This is going to happen multiple times. A lot of plans, a lot of programs will name the people responsible and throw them under the bus. It's already happening.
Yeah.
And this is where people who are in this industry have to cautiously find themselves at what are they going to do if anyone who has participated in this kind of schematics where a health plan or a provider group has just created the code out of nothing, thin air. We have this example of Soul Medical Group that was, I think, a month and a half ago, 2 months, where documentation of certain couple of diagnoses were perpetuated through a scheme involving the radiologist. That reminds me of the Kaiser case.
Hmm.
And Kaiser, which is still under litigation, no comments whether it's valid or not. It's clearly saying, if one was to read it, is five whistleblowers came out, and DOJ took a lot of time to understand, like, what exactly is the fraud here. Took them years to understand that, oh, this is how it is done.
Hmm.
Physicians are involved in there, educators are involved in there. Just because somebody thought, go back into the medical record and add these lines, go back into the claim systems and add these lines and rebuild them. I mean, this is the low hanging fruit for DOJ to find out and saying,
Yeah.
hey, what do we call it? It's FRA AUD, big fraud. Like,
Yeah. Your addendums are everywhere.
yeah. And somebody going out and saying, let's work with the radiologist, let them write something here, then we'll pick up that spondylothiasis and spondylopathies and just come out with creative way to put in E&M and copy paste and say, give us $6,000 on these two diagnoses every year.
Hmm.
And it is running into thousands. I mean, what is this? Is this patient care? I mean, shame on those people
No.
who actually perpetuate these kind of activities,
Hmm.
because this is not healthcare. We are in a noble business, not creating garbage out of nowhere and reporting and getting the money. I mean,
Yeah.
it should be dealt with very strictly, and
Yeah.
that's where it's going to go. Is, you know, speaking of which, is now is the time to defend, to set the program right. What has happened. Someone should go back, and if they find themselves in trouble, then take some legal advice. And government is also always open on self disclosure. Just go and fix it and say, we have a better place, better program, we have revised our working style, and there is a compliance plan and an application which is compliant. And because you cannot always go to the providers and say, please document everything.
Hmm.
You can't teach coding to all the providers because they are not in the coding business. you know
Yeah.
when everybody says, let's go and educate the providers, educate them on what? They are already well trained to take care of the patients. They write well.
Hmm.
They know what they're doing for the patients. They're very well qualified. Now, are we going to educate ourselves to talk to them? That is more important.
Yeah.
Are we going to lead with the code and say, please put this code because you're going to get money? Providers should be asking the question, why are you asking me to do that?
Hmm.
The patient does not have it. There's another important case happening in South Florida where providers was forced to add these codes, and providers kept on saying that my patients don't have this condition. Why are you asking us every time? Why these people walk into my office with big stack of papers and say sign off on this because it's important for risk adjustment? What does that mean? Eventually the provider went and reported the case,
Good.
right?
Yeah.
And it's still in active litigation. Why
Hmm.
are we forcing doctors to do these kind of things which are almost borderline fraud?
Yeah. Yeah, definitely.
They don't deserve this treatment. So any educator, any provider, coder educator that claims to go and educate a provider, I would say stop from saying that, because you really don't educate a provider.
Yeah.
Think the other way around. Can we help them write better? That is a better word.
Hmm.
Providers hate this word, provider educator. You know,
Yeah.
they,
Yeah.
they they don't like it. Personally speaking, they have actually told me that we don't want somebody to come and educate us in this way. We know better how we take care of the patient, and they're rightfully so, doing that. But when it comes to documentation, it's the managed care program responsibility to come in and see if this documentation supports it. Is there a clinical evidence? Can I do a compliant query? Like in the hospital systems, when they are putting the claim together, there are clinical indicators, and then write in a way which is, conforming to the ACDIS guideline, ICD-10 guidelines. Don't lead the provider. Show them the evidence and
Hmm.
help them, support them, save the time, and then let them write the decision plan. If a primary care doctor is going to say patient is followed up by oncologist but prostate cancer is stable, what does that mean? The primary care never took care of that prostate cancer. It's the oncologist. Let the oncologist decide. Let the cardiologist decide if there is one,
Hmm.
right? Let the endocrinologist decide if there is a pineal tumor or not, right? So these kind of diagnoses should be seen by because if the patient does have this condition, the specialist would take care of it. Then take the care to the specialist. Set up the appointment. That specialist should actually take over if the primary care wants it to be.
Hmm.
So those are the activities that have to be revised in risk adjustment in value-based care operations that take care of the patients through the right provider type. And that is going to actually work really well when it comes to documentation supporting the diagnosis, because you will have the right documentation around it.
Yes. Yeah, that specificity for sure.
Yeah.
Now, to end us out for today's episode, I'd like you to talk some about the technology that you're developing, the AI that you're using. I really love that you have that insight from both the clinical side as well as the non-clinical or the more administrative side of the industry. What is it that you're all working on to really help tackle these things and make sure that compliance is at the forefront?
Thank you. We have been working for a number of months to just figure out the workflows that are going to be revised. Given that it's all coming, it's a team of subject matter experts that have come along to find the the best way through this maze. And the one important aspect is keeping in mind that preparing your data, that any MA plan, any MSO, ACO, whosoever is actually sending it for risk adjustment and counter data is revised, reviewed from the lens of RADV audit, and that is going to be very important. And how you do an audit is really dependent on the team of experts who have put the audit together.
Mhm.
For example, if an auditor is the same person who works within the same organization and is best friends you're going lunch with, what kind of auditor you have, right? So it
Yeah.
has to be independent. It has to be data analytics driven. It has to be suspect driven. Like underreporting is also a problem.
Mhm.
Underreporting where diagnosis should be reported, plans and provider groups are losing on it. So finding those underreported and borderline RADV uh, triggers is the key. And at the same time, bring the care plan. Think about the clinical evidence and the care plan, that why some other things which are not yet reported meet absolute necessity at this point, because You don't want patient to be seen at a hospital or in an ER, because that's where the economics of value-based care is. If certain number of patients go have admissions or readmissions, then the whole value chain is disrupted from the lens of business point of view, because it's going to cost a lot if the prevention is not in place. It goes back to the same measure, is that can I help the patients stay healthy, and can I do this from data analytics and the coding and documentation workflows? Because if I don't identify it, a stitch in time saves nine is the best example here. So when the data gets reported, look for underreporting and overreporting. So this all has to come in a particular workflow and a particular sequence and a resequence. So within the same year, when the risk adjustment is being done, we want to know which patients are in which category. And this is all about how the analytics should be developed and the workflows should be there. And the use of AI should be in different places as a multi, system approach to look at from end to end. And that is what we have developed so far, and it's already working out really well for our clients, because this is the way to do risk adjustment quality in a value-based care arrangement, helping the patients and the doctors,
Mhm.
because doctors don't need too much of jargon coming in. Let them take care of the patients first, because that's going to be more important, and let the administrators run a very good machine that works with evidence, works fast, and the sequence helps them cut down the number of steps and the number of resources that are needed, and deploy in a way that helps them to be fast
Mhm.
and effective. So that is the real, I think, crux, where if this put in larger systems would work out really in their favor, because they all care about his patients and their well-being. So this is what we're doing.
Yeah, yeah. And when I had a chance to see the demo that you provided for me, that's a lot of what I saw, the way that the monitoring can be done through the data. And then, comparing it to my own experience in projects or other entities that I see doing validation work, it's all very manual, which takes a lot of time. It takes a lot of people. It takes, the worry about accuracy and things like that. So, yeah, I
Yeah.
definitely see how this is going to be a powerful tool to help
Mhm.
identify and, like you said, tackle from both sides of the industry.
Tackle both sides, look at underreporting, overreporting, help the patients, the ones who are vulnerable, and also help our administrative team. Like, auditors should get this help, because if someone is a risk adjustment auditor, they themselves need a better way of doing things,
Hmm.
not like going into five different systems and business analysts and everything. So we took into account all that matters in this area, all the touch points, because one way of doing things is that the risk adjustment team is in support of the clinical team. So a coder and an auditor, a biller, they're actually part of this important clinical value chain.
Hmm.
They should actually take their responsibility as a support to the clinician, because clinicians are busy. We need to support them. So a coder, from my perspective, an auditor, should see themselves that, am I helping the patient here to drive the care forward? I'm a part of this ecosystem and a part of, as a citizen of this country and a part of this healthcare system. I chose to work in this area, and how can I support my provider and my employer, my healthcare network, to support this patient, which is on my screen. I don't see as a number. I'm going to drive this person's care forward and help my clinician get to this patient faster, because this patient could be someone's father, mother, daughter, relative, anyone. Just think from that lens. Every day, someone, I always say this, think that this is the patient you want to help through documentation. The ones who would remember this would then see that they are going to be themselves very happy working in this area. They're not just putting in codes and verifying and saying yes or no. They're
Hmm.
going to help the patient. So that is the mantra behind success in value-based care, and it should be done that way.
Hmm. Well, thank you so much, Kush. This was really fun. I always enjoy the different conversations we have and your insight. So thank you so much for joining. And I will go ahead. I've tagged him in a lot of the content we've had on LinkedIn, but I'll make sure that that's linked on all of the different platforms as well if you're listening in through on demand on the different podcast app.
Mhm.
And we will see you all next week. Thank you.
Thank you, Stephanie. Pleasure being with
Yes.
you. Bye bye.
Bye.